we're going to be reviewing the Medicare coverage of opioid treatment programs. My name is Rachel Wood. I'm one of the nurse analysts with the Provider Outreach and Education team. I'm joined today by my fellow nurses in Provider Outreach, Mary Sue and Jennifer, who are going to be helping me with our chat, any questions that come in this morning. And we are going to be looking into the chat. Probably we'll have question or time at the end for questions. So please send those to all panelists. If we don't get to your question today or we don't have that information, we will follow up via email. And then additionally, if you do have the need to, follow along with our slides, we do have those on our live events page. So if you navigate to this event sign up, there should be a download option, and you can download the slide deck and follow along as I go through this presentation. All right, so our disclaimer is on our slide here. This applies to all our events. Basically what this just says is that this presentation and education is for informational purposes only. Updates to Medicare happen from time to time and do happen often. So anything that comes out from Medicare, any CMS communications, do take precedence after we complete our webinar today for the most up-to-date rules and regulations. We are recording this, as I said, and we will post this to our YouTube channel for an encore presentation, so no need to record this yourself. But if you want to watch it again, it will be out there as an encore presentation in the next couple days. All right, so this is just for your reference, the acronyms that will be used throughout our slide. Pretty straightforward, but again, use this just to refer back to if there's anything in the slide deck that you're not familiar with. Okay, and so this brings us to our agenda and our plan for this webinar. So as I said, I'm going to be talking about opioid treatment programs, but I'm going to start with a little bit of background first by going through some of the current behavioral health initiatives that Medicare has, out there and going on. And then we're going to talk about coverage for opioid use treatment and some of those options there. We will go into then more detail on opioid treatment programs and what they are and how to enroll and so on, and then helpful resources and questions as they come in. We did hold a webinar covering some of this material back in last month, back in February. So some of it will be repeating just for those that may not have attended. We did want to make sure we got the info out to everybody. Additionally, with that, we do have a related to mental health and behavioral health services, another webinar coming up at 10 a.m. today that is going to talk a little bit more about some of the Medicare behavioral health initiatives as well. So if you're interested, please sign up for that. It is coming, it is today right after this webinar. So a little bit of background on the recent mental health initiatives before we get into the info. These went into effect in November of 2023 and are related to change request 13389. So those that are not familiar, change request is just a communication from Medicare making an update. Providers were sent a letter from WPS to communicate this information about what those Medicare covered behavioral health updates were. So just kind of some background on, the basis for why we're talking about this today. All right, so I want to talk about the goals of Medicare updates and behavioral health coverage. So first and foremost, the goal of these updates and changes is to ensure that they are providing high quality behavioral health services and support these services, making sure that they're accessible to Medicare beneficiaries. So the focus is on people of all ages. We serve them at every stage of life, people with, that have currently or are at risk for developing substance use disorders, maybe those with chronic pain or acute pain, or those with mental health challenges. So Medicare does have a 12-step initiative that they do have available on their website. This includes some information, and it includes strategies on their different initiatives. So that includes behavioral health integration, including the collaborative care model, psychotherapy for crisis, and opioid use disorder screening and treatment. The first two that I just mentioned, the behavioral health integration and psychotherapy for crisis, we are providing separate webinars to cover that and cover a little bit more detail on what those include. So keep an eye out if that is something that you'd like some more information on specifically. Some of the key areas that the behavioral health priorities for Medicare include are listed on our slide here. So priorities are going to be to advance the Health and Human Services roadmap for behavioral health integration. Additionally, with that, the overdose prevention strategy and the pain management task force report. Key areas that these are focusing on include substance use disorder prevention, treatment, and recovery service, ensuring that beneficiaries receive effective pain treatment as well as management, and then improving those overall mental health care services. So that kind of loops into those opioid treatment programs and why we're talking about that today. And then additionally, we will talk about this a little bit on the next slide, health outcomes and the ways that they're measured. So coverage, access to care, quality of care, equity, and then data analytics. All right, so, again, as I said, some of the things that Medicare is covering are listed on our slide here, and some of these updates related to that recent change requests. These are the key areas that are focused and align with Medicare's overall focus of the 4 health outcomes. So again, that includes coverage and access to care, quality of care, equity and engagement, and data and analytics. As I mentioned on that last slide, there are some more details that define what each of those categories include, because, saying coverage and access to care is kind of a broad umbrella term, but I don't want to go into that completely today. But that information is included on Medicare's website, and if you are interested in that link, please let us know, and we can, direct you out to that. All right, so I want to talk now about some of the coverage options that Medicare will, in the next couple slides, cover for screening patients for opioid use. So first is going to be, again, screening patients for opioid use. So who can perform this? So this can be done by physicians, non-physician practitioners, and, we got this question a lot in the last session that we held on this. So I just want to make that clear. Physicians and non-physician practitioners are eligible to perform these screenings. Medicare will also pay for treatment services for those patients that are diagnosed with opioid use disorder, and I'll talk about some more of the screening options in the next few slides here. All right, so a couple different areas and places and types of visits that these can take place. So Medicare covers screening for opioid use disorder as part of the IPPE. So this is a required screening element. During this visit type, providers are required to review any current, opioid prescriptions, any potential risk factors present for opioid use disorders. Details on what that might include are included in the Medicare Learning Network educational page for Medicare wellness visits. And then additionally, they should be, during the IPPE, looking to evaluate pain and severity of current treatment plans or provide info on opioid treatment options if needed. With the advanced or annual wellness visit, so the AWV, this is also a required screening element. Some of the things that providers should be looking for and asking about in this visit include a health risk assessment and those related additional components, and then refer patients out to treatment as needed. So during these visits in the physician office or outpatient settings, that's where these can occur. And we're going to talk a little bit about, when providing the opioid use screening option, using the screening, brief intervention, and referral to treatment, or SBIRT model, because that is something that is related to this screening and covered service for Medicare beneficiaries. All right, so I want to talk about SBIRT and just define what this is and what this entails. So this is an evidence-based early intervention approach, and the goal with this is for people that are with non-dependent substance use, and to target them prior to needing extensive or specialized treatment. So you're getting in that early action intervention. This may be used during office or outpatient visits to screen those that are not actively seeking substance use help. In a primary care setting, providers may screen people across the board systematically who may not seek substance use help, and offer this SBIRT treatment service to, kind of provide access to the following areas: reduce healthcare costs, decrease the drug and alcohol use severity in their patient population, and reduce the percentage of patients that are going without specialized treatment. So during visits in the physician and outpatient hospital settings, Medicare will pay for this SBIRT treatment service, and it does depend on the amount of time that is provided. So the duration of the service, if it is 5 to 14 minutes, you can bill for the G2011. If it is longer than that, different codes may apply. So you do want to look at those IOM guidelines, those CPT guidelines for what code applies based on the amount of minutes you've performed with your patient. All right, so some components of this include screening. So first, starting with screening, providers are going to assess the patient's risk for substance use behaviors. They're going to do this with a standardized assessment tool, and this can be done to quickly assess a patient's substance use severity as well, if it already does exist, and then identify that appropriate treatment level and best, next step of action. Next component would be brief intervention, and this is going to based on what that assessment tells us, but that brief intervention is going to increase the insight and awareness, as well as talk about some of those motivational change behavior and needs for the specific person. Here, we want to engage with the patient in a short conversation, and again, see what our next best steps approach are going to be for that patient-specific, intervention. And then finally, referral to treatment. So this is the final component, and this is what it sounds like: referring the patient to the appropriate treatment. So maybe that's therapy or specialty care services. All right, so this just covers who can provide this to Medicare beneficiaries, physicians, and then those relative non-physician practitioners that are listed on our slide here. All right, so motivational interviewing kind of goes in and ties in with this SBIRT approach. It is not something that is, necessarily a separate Medicare billing item. It's more of a technique that providers can use to get good information out of their beneficiaries. I used to work in mental health care, and we did a lot of this. It's a good way to, motivate behavior change and kind of understand what are the goals and where's this person at, where are they at relating to willingness and commitment to accept change, as well as to accept any treatment interventions. Because, while providers have good intentions, if there's no patient buy-in, especially with substance use intervention, that's going to be a losing battle if you're providing treatment, but they're not willing to buy in and follow those recovery steps. So motivational interviewing is a person-centered, non-confrontational approach, and the basis of this is that the interviewer listens reflectively and demonstrates, empathy, engaging with the patient, and hopefully developing a solid rapport and trust. So main goals would be to identify, what is the behavior that we're trying to change, and how is this going to be reinforced with that person's internal motivation to change, and then finally, what are the best steps to help this person actually change and, develop a plan of action to achieve their goal. So motivational interviewing, again, just a technique that I think, a good approach, good assessment model, and something we just wanted to, mention today, as it does relate to a lot of different mental health, treatment strategies. All right, so a couple different options that brings us into our opioid use treatment options that Medicare will cover. I did just briefly want to mention the first two, and then we'll talk in more detail about the opioid treatment program, because that is what we're covering mainly today. Some of the things that Medicare will cover, though, related to opioid treatment include evaluation and management visits for medication management. So that is going to be code-dependent on, what you're doing, but you can use E&M visits to provide medication management to make sure patients take their medications properly as they are part of that recovery process. The next item on our screen here is office-based substance use disorder treatment services. This is a way for you to bill for services in the office setting. Medicare does cover a monthly bundle for services, especially for those patients that are prescribed buprenorphine or naltrexone in the office setting. And then finally, opioid treatment programs, or OTPs. So these are more comprehensive treatment options, and we will talk more about this in the next couple slides on, what those include, how to be an enrolled provider, and some billing information relating to opioid treatment programs. All right. So I've talked a lot about some different things, but now I want to focus on opioid treatment programs for the remainder of our slides. So what these OTPs are is that they provide medications for opioid use disorder. So this can include methadone, buprenorphine, naltrexone for those patients that are diagnosed with, again, opioid use disorder. OTPs must be certified by the Substance Abuse and Mental Health Services Administration, and as well as be accredited by an independent SAM, or that acronym, approved accrediting body. So consider referring your patient to an OTP if this would, be something, a specific medication management for opioid use disorder is something that they need, and they need a little bit more intensive therapy to help their recovery. Part B does pay for medications for opioid use disorder provided by an OTP. There is no copayment for OTP services for Medicare patients, but the Part B deductible will apply. Patients with Part B and a opioid use disorder diagnosis are going to be eligible to get those treatment services at an OTP. And some of those may include providing medication assistant treatments for Medicare beneficiaries with these diagnoses. And again, they must be accredited by that service, independent and certified to apply for these OTP programs. And additionally, must be enrolled with Medicare as an OTP to be able to bill for these services. So we did include a list of current Medicare enrolled OTPs on our slide here. If you are interested in, who that might be and where that, who might be the nearest one closest to you. Okay, so what coverage do these include? So I kind of have gone through this a little bit already, but again, it is something that is covered by Part B of Medicare. And with these OTPs, Medicare will cover the following services that are listed on our slide here. So FDA-approved opioid agonist and antagonist medications that are related to opioid use disorders. It will cover dispensing and the administration of those medications, substance use counseling, individual and group therapy as necessary, toxicology testing, intake assessments and activities, and periodic assessments, as well as intensive outpatient program services. So Medicare will pay for the treatment for these through bundled payments, and the covered services, again, include everything listed here. So one other thing we wanted to mention as far as things that are covered, there is a option for OTP to be done in a mobile setting. So that is something that is, if you did have some more questions, we can provide info on as specific, because I believe Medicare has changed in their rules, updated them from the public health emergency to what they are now. All right, so what type of credentialed physician can perform these services, and do they have to be enrolled in our PICO system? So that is something that we've been asked by providers before, and so Medicare Part B covers these services for freestanding OTP facilities and hospital outpatient departments. So you do have to be enrolled as a Part A or Part B provider to be able to provide this benefit, and as well as you have to be accredited by that accrediting body as listed on our slide here. So as a institutional provider, you are able to enroll in either PICOs, using PICOs, I should say, or through the Medicare enrollment application using the CMS 855A, and you'll be able to submit your claims electronically through the 837I or paper claim CMS 1450 form. That's for, again, institutional providers. For professional billing providers, you do have the option to, again, use PICOs or enroll using the CMS 855B. You'll have your claims electronically submitted as an 837P or by using the claim form CMS 1500. All right, so just some information on that. Additionally, with professional providers and claims for opioid OTP services, they should use the place of service code 58. And there is more information on this enrollment in the Internet-only Manual 100-04, the IOM Chapter 39, Opioid Treatment Programs, that talks more specifically on the certain codes that should be used and what those code descriptions are. All right. All right, so I want to talk a little bit in the next couple slides about some of the billing standards. So this is just some basic info that we'll go through. And first, I want to start off with the standard billing cycle. So the duration of an episode of care for these treatment services is a week. So that is a continuous 7-day period that may start on any day of the week. So that is how Medicare defines this for these services. The threshold to bill an episode of care will be at least one treatment service was furnished for opioid use disorder. That can be either from the drug or non-drug component. The Internet-only manual does go into more detail about what is included in that drug or non-drug component. That does have to be provided to the patient during the week that corresponds with the episode of care. For those receiving intensive outpatient services by the OTPs, and this will apply to G0137, the HCPCS code, the threshold to bill is a minimum of 9 services over a 7-day continuous period. So again, for the codes that are described as a weekly bundle, so that is listed on our slide here, G2067 to G2075, as well as HCPCS code G0137. We define, or Medicare defines 1 week as 7 continuous days. So OTPs may choose to apply a standard billing cycle by setting a particular day of the week to start all of the episodes of care. So in this case, the date of service would be maybe the first day of the OTP billing cycle. If a beneficiary starts treatment at that OTP on a day that is in the middle of that OTP standard billing cycle, they may still bill the codes that apply for that episode of care if it is provided that if it meets, the threshold amount to bill for the certain code. All right, and so another option that OTPs have is they may alternatively choose to bill a weekly billing cycle that varies across all patients. So what I just mentioned was about a standard billing cycle that would be adopted for all of your patients. The other option, again, as we're talking about on this slide, is to adopt a weekly billing cycle that's going to vary across different patients. So with this approach, the initial date of service is going to depend upon the date of the week that the patient was first admitted to the program or when Medicare billing began. So under this approach of adopting this type of weekly billing cycle that will vary across patients, when a patient is starting treatment or restarting treatment after a break in treatment, the date of service would reflect the first day that the patient was seen and the date of service for subsequent consecutive episodes of care would be the first day after that 7-day period ends. Additionally, for codes that relate to any add-on information, those add-on codes, the date of service should reflect the date that the service was furnished. So 2 different options there. There is some more info if you want, a little bit more detail in the internet-only manual on, doing a standard billing cycle versus adopting a cycle that is going to be patient-specific. Okay, so some more info on billing in recognition that there is a range of service intensity depending on the specific patient and their needs and the stage of treatment. A full weekly bundle may consist of very different frequencies for the service provided, in maybe the initial phase of treatment compared to a patient that is in maybe the maintenance phase of treatment, based as well on other factors, so they maybe have a history of relapse or they have some other medical conditions to take into account. So some billing highlights that we wanted to mention on our slide here. First is going to be that providers must provide at least one service, so as I've mentioned, either a drug or non-drug component to the patient during the week of a corresponding episode of care. If no drug is provided to the patient during that episode, bill the G code that describes the weekly bundle without including the drug. So bill at least one service in the non-drug component. And then, so that is, kind of a synopsis of what we've mentioned with our other slides, but just we wanted to reiterate some of these pieces. So more information here, a little bit more on billing that we did include on our slide. Resources for these, if you want more on both the coding and just coverage in general for this OTP treatment model. First would be the Internet-only manual, section 100-02, Medicare Benefit Policy Manual, chapter 17. So again, that's 100-02, chapter 17. And then another good resource is going to be found in the Internet-only manual, publication 100-04, chapter 39, Opioid Treatment Program. So again, that's publication 100-04, chapter 39, and then OTP would be the chapter and the header you're looking at. So on our slide here, just a couple more things relating to billing. For those that have applied to the G0278 and G2079, the date of service is going to need to reflect, and these codes are related to take-home supply of medication. The date of service for these codes should reflect the actual date that the medication is provided or the first day in the weekly billing cycle that the patient receives their supply. So that's something we got asked in the last time we presented this and wanted to just make sure we mentioned again. And then last item on our slide here, the G2216, so take-home supply of injectable naltrexone is, when billing for this, round to the nearest whole number for the dose that's provided. Right. So here we have just some resources, links to our more information on the opioid treatment programs, a link to the Medicare behavioral health strategy, and then finally a link to that chapter 39 internet-only manual chapter. So the one that I mentioned, that one has some good information on add-on codes relating to what to bill for these programs. All right, so that is all I have for our formal presentation here. So I wanted to, I'll check now with Jennifer. Do we have any questions?
There's no questions in the chat yet.
Okay, thank you for attending. If you want some more information on Medicare behavioral health initiatives, please log into our webinar and sign up for that webinar at 10 a.m. today. And otherwise, we want to thank you for your participation and hope to see you at future events.